your timer, and here is your question. Right. If you have read and understood, considering the examination station, kindly begin.
Yes, I will start by wash my hands and
Yes.
start. Hello, I am Mr. Ghazir, one of surgical doctors here. Can I confirm your name and age, please, sir?
I'm 56 years old. I'm John.
John. Nice to meet you, John. Today I'm going to examine your tummy. It will include look, feel, tab, and listen through your tummy. Do you agree with this, Tommy?
Yes. Yes.
Okay. Do you have any pain at the moment?
Yes.
Can you point at the site of the pain, please?
Yes. Pointing in the center.
Center of the abdomen, of your
Yes.
tummy?
Yes.
Yes. I'm sorry for that.
And
So
it radiates, yes, to the left shoulder as well.
I'm really sorry for that. I will try to be gentle as much as you can. So are you in need for to prescribe any painkiller or analgesia before starting examination?
No,
Or
that's
you
okay.
okay? So if you don't mind, can you lay down on the couch?
Yes.
But before you can take off your gown, please. So now I will start by feel your tummy. Will be start to be as much as you can gentle.
First
Let me know
inspection.
if you. Yes, I will start. Do you have any pain or tenderness in your tummy?
Yes. Yes.
Okay, so I am really sorry for that. I will the patient jump in pain. I can't do formal abdominal examination. I will start assess through ABCD approach of Chris patient. I will consider that he is talking, so the airway is patent. Considering please two things: oxygen mask for the patient at least for 2 liters, and pulse oximeter at the lead rhythm. I will now assess the breathing with the patient. Tom, please, can you open your mouth and stick your tongue up, please, to detect any central cyanosis? So now I'm going to feel your windpipe, maybe a little bit uncomfortable. Now I am going to take or wrap your chest between my hands, maybe a little bit comfortable. I will take 3 zones, supramammary and the inframammary and the mammary line to detect a chest wall movement, and will also will observe limitation of movement either in the chest or in the tummy due to maybe presence of peritonitis or peritonism. Now, Tom, I will tap through your chest, maybe little also uncomfortable. I will start supraclavicular, then anterolateral aspect of the chest, at least 3 zones in hurry or in shortage for examination. The patient, can you lean forward or you still have tummy pain? If you still have no pain, I will skip examination of the posterior aspect of the chest. Now I will listen through your chest by my stethoscope, anterolateral aspect, equal, and take a breath in and out. So I will go through the circulation. Can you please turn your head to the other side to detect any congested neck vein? I will also look for the eye for any signs of dehydration. Stick your tongue out and out to detect any dehydration. I will assess the field pulse in your hands, temperature also. capillary fill. Now I will listen through your, will feel the apex of your heart. Now I will listen through your heart to detect any murmur or audible heart sound. Now I will go for disability. The patient is conscious. Now I will squeeze your cuff muscle, please, to detect any TEDs or tender cuff muscle. Press your legs to detect any lower limb edema. Considering expose the lower midline scar, dressing to detect any soiling or presence of fecal material. Okay, so now I finish. Now considering I need to see the drug chart and patient vital charts, please, as a CRESPO protocol for the patient. Now I finished my examination. You can dress now. I will pass my. I will detect the temperature for the patient. I will pass my notes to my consultant to figure out your issue. So today I examined. Now I will present my case.
Okay.
Yes, I today I examined John, 55-year-old, who presented with acute shortness of breath with generalized abdominal pain. Post-operative day 6 day. We referred to the shoulder tip. I started the formal examination, but the patient jumped in pain. So I assessed according to CRESPO protocol ABCD approach. The airway is patent and with limitation of the abdominal movement and chest wall movement, but normal central trachea, no central cyanosis, bilateral equal air entry with no added sound. Also, pulse is feel with no delayed capillary fill or the central cyanosis or the signs of dehydration. Also, audible heart sound S1, S2 with no audible murmur. As regards the disability, the patient is conscious. The patient has a lower midline scar with soiling of fecal material or mostly infected. No tender cuff muscle, and no lower abdominal, lower limb edema.
So what are your differential diagnosis?
Yes, after examination and short patient, my differential diagnosis is peritonitis due to anastomotic leakage, as the patient is tachycardic, tachypneic from the chart with increased oxygen requirement and pain analgesia requirement. Also, ECG is revealed AF, maybe due to electrolyte disturbance. Also, the patient with leukocytosis and laboratory investigation. So according this, I will order some investigation in the form.
How would you manage this patient?
I will start by laboratory according to ABCD protocol, but order some investigation form of ABG and ECG, cardiac enzymes, considering normal renal function, also to exclude pulmonary embolism, CT pulmonary angiography, but the most important to do a CT with gastrographin image to detect the line of anastomosis, but the patient must be managed in form of nail per mouth, urinary catheter, HDU with CVB insertion, to detect for monitoring and the fluid, and the correction of the AF in form of electrolyte disturbance in renal function. Then prepare the patient for abdominal exploration, for peritoneal toilet firstly, then Hartmann procedure for in form of proximal exteriorization and the closure of the distal stomach.
All right. Yes, time exactly went.
Yes, thanks.
Right. Yes, Dr. Mohammed. One, I don't know, you just told me before, so I can assume you were tired, you didn't have enough sleep. So one thing, when you approached the patient and you identified the identity of the patient, then you took the consent, right? Then you were supposed to do or start from inspection of the abdomen, right? So yes, you, I think by mistakenly started direct from palpation.
Yes.
So yes, First you had to do the inspection, like general abdominal examination, right?
Yes.
And then
Yes.
you go ahead with inspection, palpation. And then
Yes.
for palpation, you'll start with the iliac fossa, and then you'll go up. Okay, and then the moment you'll put hand, all right, you asked, and that everything was all right. And when you even did the CRISP protocol, I think it was all right. But then once you were asking patient, in this one as well, because it's an emergency or CRISP post-operative CRISP patient, so patient will have a mask, oxygen mask. So when at the end you'll put the mask back, you'll thank the patient. Yeah, these are the small things which I think I could take. Anyone else want to give feedback? And one more thing, yes. In between, I thought that you were mentioning the wrong.
Mention what?
The wrong name. Tom, I think you said. It was John, I told you. And
John,
then, yeah.
John.
You'll hear
Yeah.
the recording again, you'll realize. And the age was not 55, it was 56. So I think, yeah, but if you would have taken enough rest, then you would have done a lot more better with small things, you know?
Yeah.
Yeah, otherwise it was good. Like you covered everything, but in the beginning you missed one part.
Yes.
Because even in the examination in front of examiners, if you'll go direct for the palpation, they realize, oh, you've missed one thing. So you have to at
Yes.
least stand at the end of the bed to make sure that you are looking at the abdomen, and then maybe you can tell yourself, okay, abdomen looks distended out, and there is a scar with the dress. There is a dressing soaked or with soilage or whatever you look. So there are no spider nevis, there is no other pigmentation, there is whatever. You look at the tummy, so you can say that, or abdomen of the patient. So good, thanks.
Yes. So, ma'am, excuse me. As
Yes,
regarded the general look from the bed or from the side, for a look for example, a limitation of abdominal movement,
yes.
you need also to look for hand spider nevi and so on.
No,
I will.
just for the abdominal
Yes,
abdominal
just all
general
movement.
examination. But then
Yes.
you did the CRISP and you did it very well. But in the
Yes.
beginning, once you are doing, you will start with the general abdominal examination.
Yes,
And
from the
then,
end of the bed.
yeah.
Yes.
Because if you'll do it from the side, it may not show you the whole abdomen. But if you're doing it from the rear end, it will give
Yes.
impression to the examiner that you are examining the abdomen. Examiner
Yes.
is in front of you. So
Yes.
after exposing, of course, so
Yes.
this will give,
Thank,
yeah, a positive impression.
yes. Thanks, ma'am.
Thank you.
Yes.
Started the timer, and here is your question. Right. So if you have read and understood, considering it surgical anatomy station, kindly identify in picture A, what is 3, please?
3 is the head of the femur.
Yes. What is 2, please?
2 is the greater trochanter. 6 is
Yes.
the femoral neck.
Yes.
4 is the intertrochanteric line.
Yes.
5 is the lesser trochanter.
Yes.
And 9 is the shaft.
Can you please tell me
And,
the importance of the neck of the femur?
The neck of the femur has a blood supply which runs from distal to proximal.
Yes.
So in fractures around the neck of the femur, the blood supply to the head can get damaged and can result in the vascular necrosis of the head.
Okay. From where head of the neck, this one identifies as what?
One is the
Picture B?
fovea.
Fovea. This,
In picture B.
what does this signify? What does this shows you?
Fovea shows the attachment of the ligamentum teres through which the artery of the ligamentum teres enters,
Very good.
which provides not much significant blood supply to the head of the femur. The
Very
major
good.
blood supply comes from the retroculateral arteries.
Good.
5
What
is
is
the
this?
lesser trochanter.
Very good. Okay. 11.
11 is the trochanteric fossa.
Yes. What's the significance of trochanteric fossa?
I think the obturator internus inserts onto the trochanteric fossa.
Okay. Can you please tell me what is 3?
3 is the quadritubercle.
Yeah. Okay. This 3 is not same as this 3. Okay. So what is 12, please?
12 is the endotrochanteric crest.
Is it crest or the
5 is
or ridge?
endotrochanteric
Is it crest or ridge?
ridge, I think. I'm sorry, I'm not sure.
Yes, in exam, don't say I think. You have to be sure. Otherwise, it becomes doubtful. Okay, what is 8?
8 is the lesser trochanter.
Okay, cool. 9? This 9 is the same as this 9.
Shaft of the femur.
Good. Okay, what is this? 11? From the top?
11 is the neck of the femur.
Okay. Right. This is 8 in picture.
8 is again
C.
lesser trochanter.
Okay, looking from the above. All right. Can you please tell me how this hip joint is formed?
Hip joint is formed by the articulation between two bones, that is the acetabulum and the head of the femur.
Okay. What type of joint is hip joint?
It's a synovial ball and socket joint.
Okay, what strengthens the hip joint and where hip joint is weakened? Or what are the weaknesses of hip joint?
The hip joint is strengthened by muscles as well as ligaments.
Yes.
The ligaments are the iliofemoral, ischiofemoral, and the pubofemoral ligaments.
Yes.
And the muscles that cross the hip joint are the iliopsoas,
Yes.
then the rectus femoris, then the posterior muscles, including the gluteus
Okay.
maximus, medius minimus.
Can you please tell me what are you looking at? What is this?
That is the iliac crest.
Good. Can you identify this muscle, please, quickly?
This is a posterior view, so that's the gluteus medius muscle.
And this one?
That is the gluteus maximus muscle.
Okay. Can you identify this little muscle here?
The inferiormost is the quadratus femoris muscle.
Okay. Can you please tell me the attachment of quadratus femoris muscle?
The quadratus femoris originates from the ischial tuberosity and inserts onto the posterior surface of the greater trochanter.
Okay. Where? What does it? Is it supplied by?
It is supplied by the nerve to quadratus femoris,
Which is a branch of?
which is a branch of the sciatic nerve.
What are the actions of
It's
quadratus
an external
femoris
rotator.
muscle?
Quadratus
Okay.
femoris is an external rotator of the hip joint.
This last tip is pointing at what?
It points to the ischial tuberosity.
Okay, what is the significance of ischial tuberosity?
It gives attachment to all the hamstring muscles as well as muscles like quadratus femoris.
Okay, good.
Then
Can you please tell me what kind of image are you looking at? Can you
this is an
describe the image?
angiogram of the femoral artery and its branches.
Okay, can
Number
you please?
2 is the
Yes.
common femoral artery.
Number 1 is what, please?
Number 1 is the external iliac artery.
And 3,
3 is the lateral circumflex femoral.
4,
4 is the medial circumflex femoral. 6 is the profunda
Okay.
femoris.
yes,
7 is the superficial femoral,
and 5.
and 5 is muscular artery.
Okay, can you
Um,
please tell me how many compartments there are in the anterior thigh?
In the thigh, there are 3 compartments:
Yes,
anterior,
yes.
medial, and posterior compartment.
Okay, what are the muscles of anterior compartment?
Anterior compartment muscles are the pectineus, iliopsoas, then the
Okay.
quadriceps, which
Can
include
you please
the
quickly,
rectus.
yes, tell me the structures found in the femoral sheath?
The structures found in the femoral sheath, are starting from medial to lateral, are the
Yes.
lymph nodes, then
Okay.
the femoral vein,
Yes,
and the femoral artery. Femoral nerve is outside the femoral sheath.
very good.
Is located.
Okay. Can you tell me the boundaries of the femoral triangle?
The
How
femoral triangle,
yes.
the lateral border is formed by the medial border of the sartorius muscle. The medial border is formed by the medial border of the adductor longus, and the base of the triangle is formed by the inguinal ligament. And the floor is formed by the pectineus and the iliopsoas and the adductor
Medial to
longus.
lateral. Medial to lateral.
Medial to lateral.
Okay.
Adductor longus, pectineus, iliopsoas, and pectineus.
Okay. Can you please tell me what are the contents of the femoral canal?
The femoral canal is the medialmost compartment of the femoral sheath. It contains the fat, lymphatics, and sometimes a deep inguinal lymph node of clocket.
Okay. Can you please tell me the pathological, physiological and pathological significance of femoral canal? One physiological and one
The
pathological.
femoral canal lies just medial to the femoral vein. So,
Yes.
in cases of increased venous return through the femoral vein, it acts
Yes.
as an area for the femoral vein to dilate and accommodate the femoral vein. And pathologically, the lymph nodes, in case of lymphadenopathy, sorry, I don't know.
It's a weak point, you know.
Uh-huh.
So rest, you tell me what happens in the weak point.
Femoral hernia.
Hernia can take place. Okay, can you
Hernia
please
can
tell me what is vascular lacuna?
Vascular lacuna lies medial to the deep to the inguinal ligament,
Not
and
deep,
it
actually,
contains
behind and below the inguinal ligament.
behind below the inguinal ligament.
What does it
It
contain?
contains the femoral vein, femoral artery, the femoral branch of the genitofemoral nerve.
Very good. What is muscular lacuna?
The muscular lacuna lies lateral to the
Very good. Inguinal
vascular lacuna.
Yes.
It contains the femoral nerve,
Yes.
the iliac crest
Yes.
muscle, and the
Lateral femoral cutaneous.
lateral
Very
femoral
good.
cutaneous nerve.
Very good. Excellent. You could answer everything, and yes, that was the end. Excellent.